Good morning, good afternoon, depending on the time this is being broadcast. I am happy to present to you a study done as part of the Quality Improvement Initiative currently in Uganda, in one of the public healthcare hospitals or settings in the country. I am Dr. Ouma Edwin. I am a consultant, the project on patient safety establishment through 5S CQI, Kaizen TQM. This is a collaborative initiative between the government of Japan through JICA and Ministry of Health as a part of the global move towards ensuring greater safety of both our healthcare workers and patients in our healthcare systems. We did a baseline assessment of adverse events in one of the public hospitals, which is Kabale Referral Hospital, to understand the level of safety of our healthcare in these settings. We shall begin off by defining an adverse event as being an unintended occurrence where medical care results in harm to patients. Through our healthcare that we provide to patients, sometimes unfavorable outcomes occur to our patients and they are not related to the underlying disease at all but caused by us. While this organization estimates that between 4 to 16% of all hospitalized patients in Africa have or experience some form of adverse events to them. In our local setting in Uganda, there are no conclusive studies that let us know the incidence or the level of this occurrence in our healthcare system. So we aim to determine the baseline incidence of adverse events in one of the public healthcare settings with good 5S Kaizen practice, and that is Kabale Referral Hospital, as you may all know. After acquiring permission through the hospital leadership, through the inline directorate, the Ministry of Health, where the project is being implemented through, we did a retrospective review of medical records using a new tool in our healthcare setting that we adapted from the Americans called the Institute of Healthcare Improvement Global Trigger Tool. This tool is a new tool in our setting. However, it is flexible and very easy to use to help us identify adverse events of the healthcare that we are providing, especially for inpatients. As I will talk more about it, we'll get to learn more about its operations. The tool we did a random sample of medical records from surgical, medicine, and maternity wards, 100 records from each department, and the criteria was for discharged adult patients that had been at least admitted for 24 hours or longer in the hospital. This helped us to at least be sure that they received some form of care or they were with us for a long period of time, exposure to the healthcare system in order to experience our services and expose them to some of the possibilities of adverse events happening. And we utilized hospital staff. We trained a team of reviewers, part of the quality improvement team of Kabale Referral Hospital, that consisted of nurses and medical doctors to help us review these records. We would review records at least 3 hours daily for about a week. And they formed 3 groups in which each group had 2 nurses and 1 doctor who would authenticate the findings that they have found out in all these records. In essence, each record would be reviewed by 2 nurses, each separately, and then discussed with the doctor to authenticate it and summarize the findings of that record. And this was done for all the records that were assessed. Basically, all the adverse events were gotten using the modules within the global trigger tool that we utilized that has the care, the medication, surgical, and prenatal module with about 51 triggers. So these 51 triggers, we adapted them to our local setting because our setting is different from the American setting. And we reviewed them to ensure that they apply to our local setting. These triggers, consider them as clues that guide the reviewers or tip off the reviewers that it's possible an adverse event would have occurred in the care of this patient, and therefore they look deeper into the record to ascertain whether indeed there is evidence of an adverse event which would have occurred. So you can have very many triggers, but no adverse event. However, they help us to look out for and have a suspicion of an adverse event having occurred. We further grouped these adverse events into harm categories to determine their severity. And the categories were E to I, with E being adverse events that contribute temporary harm to a patient and required some further intervention to alleviate it. F, temporary harm to a patient and requiring prolonged hospitalization than had been planned by the clinicians or the care team. G being adverse events that contribute to permanent patient harm. H, that required intervention to sustain life. For example, if a patient was taken to ICU after some kind of intervention. And I, an adverse event that really contributed to death of a client or patient. We got the incidence by acquiring the adverse events and dividing by the total number of records reviewed and multiplying by 100 to get the incidence per 100 admissions. That incidence is very vital for us to know, and we can keep monitoring it every time these assessments are done. We also got the incidence related to patient days in the hospital, the length of stay of patients, how it plays out in that aspect. And we got the total number of adverse events that we got during this study divided by the total length of stay of all the medical records that we reviewed and multiplied by 1,000. And we shall look at these figures. Diving into the results, we got 285 patient records that fitted into our criteria. And of these patient records, 33 of them, of these records, the team was able to get 33 adverse events in all these records. With the distribution, as you can see it here, surgical ward taking the magnitude, having had 14 adverse events identified on all the files reviewed in that department, closely followed by maternity at 30% with 10, and medicine last with 9 records. As you could see the distribution, not so far apart from each other. We further categorized them to understand how harmful were these adverse events to the patients. And you could see that category E, which implied adverse events that had temporary harm to a client, however, required some intervention to alleviate it, going on to be about 18 of the 33, with examples of vomiting and PPH. These were adverse events that occurred to patients, but the healthcare providers were able to intervene and alleviate them. So they were not permanent and they didn't lead to prolonged patient hospitalization. Moving on to category F, these were adverse events that were temporary and required prolonged hospitalization. For example, surgical site infections and convulsions. Okay, so the patients had to be on the ward longer than the healthcare providers anticipated. We didn't get any adverse events related to categories G and H, which is permanent and requiring life-sustaining initiatives. However, there was one that was gotten that contributed to the death of a client, and the team that reviewed had the diagnosis as pneumonitis. So this shows you that adverse events actually occur to patients, and that's how we got them. Referring to the incidence of adverse events due to medical care, the incidence per 100 admissions was at 11.6%, which is within the World Health Organization range that's predicted, but on the upper end. And we got that 28.3 adverse events happen every 1,000 patient days at Kabale Regional Referral Hospital, with the highest incidence being in maternity, surprisingly, and surgical ward having the least, and yet it had the highest number of adverse events, which is an interesting finding. We noted that indeed adverse events occur in our healthcare findings, and it is important to have a no-blame culture to foster reporting. People fear reporting, even by writing in these records, and therefore we need to promote that by having a no-blame culture. Our major limitation was the incomplete medical records, whereby this consisted of no discharge summaries. The vitals were not in the files. Nursing notes were missing in most of the files. Investigations were not recorded. even if some of them were requested, and there was indeed incomplete clerkship of most of the files. This could probably have suggested a low rate of adverse events identified from our findings that we've got. One of the lessons learned is that 5S Kaizen is a vital foundation for error recognition and reporting in any healthcare facility that seeks to improve quality of its processes. So if you want to have orderly environment and processes, 5S Kaizen is a beginning and is a policy by Ministry of Health for all healthcare facilities. In conclusion, indeed it is feasible to get adverse events and have a measure of the safety of your services in any facility, but it has to be premised on good record keeping. Very important. Indeed, other studies need to be investigated so that we can know these adverse events are coming from which processes, so that strategies can be put in place to remedy them. Thank you so much for listening to me. I remain Dr. Edwin Ouma. God bless you.